said is you get those specialty drugs, let's say Remicade, you mentioned, right?
Right.
And you have your specialty drugs, and those companies try to reach out to the ICP and say, hey, we would like those patients to be home quicker, so let's work together to make sure that happens.
Yes, I've definitely seen that happen. It probably happens less so in the non-specialty space. I think the common drugs, antibiotics, other forms of even IVIG or SCIG drugs these days, more commonly utilized in the home. Perhaps less there, but again, they also have a relationship. So the relationship might be that this isn't an example specific to BioScript, but I'll just use their name in this instance, but I've witnessed it in other companies where pharmaceutical manufacturer will, create a new relationship for a new drug or an existing drug. Maybe their contract's up for renewal, they've renegotiated. And part of that is, okay, let's get your top clinical people from the pharma manufacturer into our company. Let's educate them on the drug. Let's educate them on the administration and utilization of it. Let's do some cross-training so that we can identify it. And in my experience, the pharma company's already done the work to figure out where most often that drug is going to be utilized, whether it be a geographic part of the U.S. or a specific portion of the population, depending on what the drug is. So it can definitely be non-specialty, but I think it probably happens more often on the specialty front because there's a lot more at risk in terms of the patient being correctly administered and getting the results that everybody's looking for.
Right. That makes a lot of sense. To add to this, would it be, let's say the patient hasn't been, would the pharma reach out to, let's say, BioScript before the patient gets discharged from the hospital, or, in the case of specialty drugs?
Oh, absolutely. Yeah. So the goal would be either for if that's the channel of communication, it could be the pharma company knows about the patient being admitted because they've gotten a call from their primary care physician or specialist. It could be the pharma rep has gotten a call from the hospital. It may not be a call. Honestly, sometimes it's just, in our industry, the person that shows up next might be the one that gets the order because someone just left 2 hours ago and now a new patient's been admitted. Mm-hmm. So it's not always very smooth, and it's not always very specific in terms of how that might work. And of course, then you also have scenarios where the health plan or the payer's involved, and the payer might be reaching out to the pharma company or the home infusion provider. They may outreach if they have a case manager on site from the payer. I'll make it up, say Aetna maybe has a case manager somewhere in Philadelphia and they have a patient that needs a specific drug. They may have a direct line to the pharma company or their top providers and may pick up the phone and call either or both because they're trying to get it done as quickly as they can and be efficient. So it can certainly happen in a bunch of different ways. It doesn't always happen as smoothly as everyone would like, but the goal is, as I said, to get people home as quickly as they can and safely as they can, depending on whether they need something in the home first. And I would say, generally speaking, that's all taken care of before the patient is discharged, because you don't want to be sitting at home waiting, unless it's something that is maybe monthly or biweekly, and maybe they've already gotten their first administration somewhere else.
Right. Okay. No, this is good. Thank you. Okay, no, I basically cut you off in the train of thoughts you had about telling us about the business model. You definitely told us about the discharge process and also how the pharma intervene in that piece of it. But Can you?
And about achieving, appropriate rates between the two companies, and then initiating a plan on how to achieve the goals that might be written within the contract. So you might say, for example, there are performance criteria. Myself being more on the managed care side, I often negotiate performance criteria into my contracts with health plans. My partners on the procurement side would often negotiate provisions or performance criteria such as where we're going to grow utilization of this by X amount, or we will make sure that X percent of our orders are for your company and this specific drug when we get those orders, because there are different manufacturers that can make the same drug, especially when it comes to generic. So is that helping answer your question?
No, absolutely. And to add to this, though, let's say I'm not in a generic. Let's just take the example of Remicade, and since we talked about it, specialty. Okay. So, what is if let's say Remicade says the maker of Remicade says we don't want to do contract with you guys. What are they losing? Like they're saying, and let's say I work for them, and I say, well, look, the doctor says to give Remicade to the patient, you're not going to say no. So what am I losing by not having a contract with you guys?
Well, I'm not sure, because you would certainly probably have contracts with other companies, right? So
right. Mm-hmm.
So that's one part of the answer, but let me answer it also a different way. I've seen manufacturers try to go direct with the health plans and direct to the patient, but they don't have the nursing and they don't have the pharmacist to provide the 24/7 care if someone has an issue with it and needs to go get a nurse out there right away or go into the hospital. So if a pharma company is looking to go full service, they may be able to consider ways to provide their drug to a network or certain providers that could provide the rest of those services, but I'm personally not aware of many, if any, manufacturers that provide the drug and they have a nursing network to administer it, and they have clinical educators, and they have pharmacists on staff to be available. Because again, remember, this isn't only, we're not only talking about perhaps retirees and Medicaid or Medicare recipients, we're also talking about a lot of commercial people that have a disease state that might last their entire lives.
Yeah.
So you're talking about long-term patients, and you're talking about, if it's not a self-injectable drug that the patient can do on their own after a couple months, they're going to need some intervention at some point. And at some point, they're going to need live intervention, not just someone on the phone. So that, to me, would be the barrier for any company that thinks they can do it all without having the service side of it. If they built the service side, meaning in-home services, that's what home infusion therapy is, or a series of ambulatory infusion centers or suites, then I think it's possible. But in the absence of that, it's really just the difference of if they don't contract with one infusion, or ITP, I think we're calling it for this call, right? If they don't contract with one, they're probably contracted with another.
Right.
And there are situations, I think, in the hemophilia space, in the there are several spaces where there are limits to the number of manufacturers and the access to the drug, specifically because the pharma company wants to make sure it's a very well-managed group of patients, because the ability for them to continue to manufacture and make the pharma company profit is based on having good, reliable results.
Right. No, thank you. And one thing I was also trying to get at, I think you hinted to this, is if they say they don't want a contract with you, you can always say, I'm going to drop you from my inventory and I won't be able to serve your patients when they get referred to me, right?
Of course, yeah, because if we can't, if the provider, If the home provider can